The impact of both stigma and trauma is something that practitioners need to consider while caring for patients struggling with substance use. We've invited 3 RAAM clinicians to speak about their experiences in addressing stigma and trauma in their practice.
So how important is acknowledging trauma and stigma when you're working with engaging a client?
I would say it's very, very important. And maybe to kind of emphasize, I'll give an example of a patient that I got involved in. Elderly woman in her 60s came through a RAAM clinic after her family physician had passed away abruptly. And she was on high doses of benzos, over 100 milligrams of diazepam. She's lived with chronic pain, she has mobility issues, she was on many forms of opiates before that, and she had run out all of that and tried to go to emergency departments to get a refill of her medications, and no primary care physician would take her care on just because of the nature of what she was taking at the time. And she came to a RAAM clinic, and our physician who was tending to RAAM that day was really great, offered a lot of support in terms of, this is something that we can help. We may need to make some changes to ensure safety and all of that, including daily dispensing and having you to go to the pharmacy. Not sure how that's going to work with your mobility issue. She had her family there, so which was good because the family was on board and was supportive. So care started on very well. And it was a male physician, white male physician, who was following her in our clinic, and things went okay for some time until at some point I think they kind of hit a plateau where the benzotaper wasn't going so well, and then she was frustrated, she was in pain, and it really escalated to some form of frustration, both in the part of the patient and the physician, that the physician expressed to me that just thinking about having this interaction with this patient on a follow-up visit was causing anxiety for him, and obviously feeling so bad that the patient had to deal with this, and the expectation that this is not going to go very smoothly, but we have to do it regardless. And so that went on for quite a bit, and it was quite stressful for all of us as a team to see. But what I learned was the strength that I think I drew up from here was, number one, the importance of the team approach when we are dealing with patients who have chronic pain and chronic substance use issues and trauma and all of that. Because we have an outreach worker in our program who right away engaged this patient and kind of tried to deflect all of that, frustration that was going to the physician, and worked and connected her with external resources. So things started to change a little bit when the patient engaged with the outreach worker, and maybe just having an informal conversation, not particularly focused on their medication, because now I'm not a physician, we don't have to talk about this, but let's talk about what's going on at home. That sustained for some time, connected with some supports, and the supports started to engage the patient outside of the clinic. Until then, the behavior then translated to the support systems, and they pulled back. They said, well, we have expectations and boundaries in organizations. We cannot continue like this. Your behavior is inappropriate, and it's really causing chaos for the agencies that were supporting us. So that pulled back. So then we went back to square one. We are the only support that you had. And it became a very desperate situation. And I remember having a conversation with this physician about what is it that is going on with this woman, because she was on first benzodiazepines, and then she was started on buprenorphine, which failed, and then there was conversation now to switch her to methadone, which wasn't an easy process because of the gradual titration of the methadone. So at some point, we decided, why don't you meet with her? And I did, to find out, what is it that we can do? And I offered to do this, and we sat down, and I just let her talk. She could talk and talk and talk for hours. One thing that I said is, could you tell me, what is it that triggers you when a physician so-and-so talks to you? Because I had sat with her, the physician, and I could see the interaction. It's almost before the physician speaks, she was already escalating. And I remember she bowed her head and she said, "You know what? He reminds me of my father being yelled at. I cannot stand another white male yelling at me. And I used to be controlled and told what to do all the time. And I am a grown woman. I am not going to take that from anyone." And that was a huge eye-opener for me. And just really validating that moment. And it occurred to me, there is some trauma here. And we talked about the role of trauma and how that childhood experience could have registered in her brain, that the only thing she came out when she had that interaction was her brain went back to that experience and the need to keep herself safe and really avoiding that threat. And that she wasn't even hearing what the physician was saying. It wasn't that the care is not appropriate or the treatment is not working. And from that moment, I went to the physician after that appointment and I shared this, and we created a care plan where every visit I will meet with her and whoever family she brings, and the physician will come towards the end. And every day we would reinforce how trauma is so pervasive, how it has impacted all these issues in her life and the contribution that it has. And this is not her fault, that she's not a bad person, she's not an angry woman, that this is her way of coping. And this has worked fantastic. She came from over 100 milligrams of diazepam on a taper now below 30 milligrams, and methadone has been titrated up, so there's a plan that every time the physician increases her methadone, then he goes down on her diazepam, and she does not struggle. And she goes to the pharmacy on a daily basis, and she has mobility issues. So I think that was a very successful approach to people who have had trauma, and also working as a team to really support the patient.
I think that's a very illustrative example because I think a lot of practitioners struggle when they get to a point with a client where perhaps these behaviors are starting to interfere with the treatment course. And I think, Irene, you bring up a really good point, because then the question maybe that we should ask is, what are the other factors that could be contributing to this behavior? And trauma may be one of them. And so perhaps it behooves us to, as practitioners, to explore that and make that a part of the treatment plan, right? As you said, part of the care plan that you and your team came up with for this woman. And in your example, it made a tremendous difference. Yeah. And so, in light of what Irene has shared, are there some things that that you all do to try to minimize stigma in your practice, or try to acknowledge trauma? What are some things that?
Well, we sort of come with that perspective, right, to all of our interactions, because we're bringing that understanding of the legacy of and ongoing impacts of colonialism and oppression of Indigenous people here in Canada on Turtle Island. So, we're acknowledging that people bring that, have had some experience of the systemic, trauma in terms of intergenerational trauma, residential schools, 60 scoops, child welfare system, just intersecting with many of those, governmental systems that people have had that experience, and especially healthcare systems as well. I think there's a criminal justice system and being overly incarcerated and underprotected in terms of missing and murdered Indigenous women throughout the country. So we kind of carry that, we bring that, we know, and when we're meeting. And so even our intake asks people if they have anyone in their family or themselves who's a residential school survivor, so we can begin there. We ask what their connection to their culture is. Has it been, is that weak? Is it very good? How do they feel? How do they feel about rebuilding that? Not everybody wants to rebuild it. We can't make that assumption. Many people do, right? So we kind of, as an organization and collectively as a team are bringing that sort of trauma-informed and culturally trauma-informed perspective to the work. So we kind of begin at that place and understand, that substance may have played a role for generations in some families, sometimes not, but we try to unravel that and connect with that person and find out what's happening for them and where they particularly are at as an individual in terms of their substance use. And we know the huge stigma, right, that just generally substance use still has in our society. And then we have that coupled with things like poverty and maybe homelessness in some people's cases, as well as racism and discrimination. So we kind of we know that we're sort of engaging and understanding all of that when we're connecting with people, and then trying to work with our hearts and minds to see like, okay, what is your particular individual story, and how can we help you with these challenges, right? How can this program or this organization, and then we're lucky that we have all the resources of the organization that we can build in as well, right? Everything from traditional counseling to mental health counseling to traditional healers that can all address those pieces around trauma, right? So that's kind of where we're coming from, and addiction medicine is fitting into that sort of harmonized approach, right, between Western approaches to dealing with trauma and more traditional cultural approaches if people are wanting that as well. So that's so I think that kind of describes where we're coming from when we're looking at that piece. Yeah, so it's very important to bring that perspective.
It sounds like it's foundational for
to our work, right? Yeah.
It's always important to remember, I think, from both trauma and stigma is, and both of you have touched on it, is the patient's experience with the medical system, regardless of race or gender. A lot of these people have come from difficult interactions with prescribers, and confrontational interactions quite often, often dismissive attitudes, and that's probably the majority of their experience with healthcare. I always think about the trauma that's induced by their experiences in healthcare, and I think that's something you always have to keep in mind. Irene's example is one of them, where people will come in kind of sometimes ready to do battle versus ready to get better. And if they come in with that feeling, they're anxious, there's a power imbalance with the prescriber, it's very difficult to get them moving along as far as their recovery. So an understanding of that is a good way to start. And to me, trauma and stigma are kind of the same with regards to that. So I always try to remind myself that they most likely have had at least a few, if not many, negative experiences in the healthcare system. And so just having having that in the back of your mind is important. And then as far as reducing stigma, just open discussion about drug use, right? What do you use? Why do you use it? No judgment. That's okay to use for now. Where do you see yourself? In a month, 6 months, a year. Do you want to stop using that? Do you not want to stop using that? I mean, so just to not judge based on what substances are being used is important, and to just have an open and free conversation about it. And so if you start with that kind of approach, then I think that stigma of drug use you can move past that fairly quickly if they know that you're asking about it. Because a lot of practitioners won't even ask, and once they do ask, and if the answer is yes, I smoke crack, then the whole tone will change in a typical medical interaction. So I think that's a good tool, just to be very open, to say, okay, what do you use? How do you use? Are you using it safely? You get to harm reduction and discussion. Yeah. And then right away they understand, okay, well, this is different, right? This person's actually wants to know about my drug use versus now knows about my drug use, but automatically is judging me and shutting down that conversation, or just saying, stop doing that.
Prescribing in terms
exactly.
of, you need to do this now.
So would you say that one of the really important tenets of being trauma-informed in your practice is to allow the client to have a sense of control over the conversation or even their treatment course at times? Would that be fair to say?
Yeah, I mean, I think there's limits to that. Irene's example is one of them. I mean, the benzodiazepine people are probably the most difficult. And so, I mean, I always try to give them options and let them know that they have choices. Sometimes there aren't choices, though, but
How do you navigate those situations?
Yeah, so I try to, and it's very hard when you get a case like Irene's where someone's been cut off and they're there, they need their benzos now. I would much prefer not to be talking about prescribing in the first interaction as much as possible. I mean, you give them some information on some medications that you think would be a good option, give them a few medications. If they're capable of reading and understanding information, they can take that home and digest it, and then you can just get to know them a little bit more. And I try to de-emphasize medications as much as possible, to be honest. I mean, a lot of people turn into what I call like chemical copers, where they think there's a pill for every problem. And so, again, the team aspect of that would be like, why don't we try not using a pill for that problem? Why don't you try talking to, the social worker, the counselor, and work on some skills or some psychotherapy aspects of getting better. So again, trying to make those suggestions and include that as one of your options. Say, you don't need another dose of clonazepam. Maybe you need to talk to somebody, and that's difficult. There's usually not great uptake, but I'm always talking about the non-medical options of getting better, because medications only get you so far.
That's an interesting scenario that you bring up, because I imagine the prescribers are kind of split, right? I think there's probably prescribers that would prefer, maybe it's easier to just write the script and, I feel good because I put them on, some sort of replacement therapy or whatever, as opposed to your approach, which is, let's try to sort out all of the different layers, and, in the hope that there's going to be uptake in terms of treatment and really getting to perhaps the origin or the real cause of why there is substance use in the first place. What would your response be to, say, a prescriber who is more, leans towards, providing a pill as a solution as opposed to going those other routes?
Yeah, I don't want to minimize some treatment options for, especially opioid use disorder. I mean, the opiate replacement therapy, especially buprenorphine, I usually don't hesitate to prescribe that. But if I have started it, I always talk about the dose increases, and have a conversation. Do we need to go higher? Are you okay? Can you cope? So yeah, I mean, I would say certainly if you're going to prescribe opiate replacement therapy, that you really should be making sure it's an informed, as much as possible, an informed decision. And again, this is case by case, right? I mean, if someone's coming to you from the emerge because they've just had a fentanyl overdose, or they've had their 4th fentanyl overdose in 6 months, they need to be on something,
Yes.
and I would have a very low threshold to get them started, because you're starting them on life-saving therapy.
Absolutely.
Right? But then if you get someone who's maybe more of a chronic pain person, who's now maybe just misusing a little bit, they're not sure where they want to go, those are the ones where I step back a little bit and be like, okay, is this the right treatment for you? So, I mean, when it comes to opioid replacement therapy, I think it's okay to actually be a little more aggressive, especially with Suboxone buprenorphine, because it is so safe. So I'll say that as a proviso. But if you're getting into some of the more anxiety stuff, some of the benzos, some of the alcohol use disorder treatments, whether it's naltrexone, acamprosate, gabapentin, I try to have more of a conversation around those ones, because they're not as life-saving. They're still very effective, but you can work with them a little bit before starting it. And I think some of those medications are better prescribed in the context of a treatment plan. I mean, same with opioid replacement therapy, but it's more important to have a treatment plan with some of those other medications, I feel. And so, yeah, that's kind of what I would suggest. I mean, like I said, there's no one-size-fits-all solution to any of this. But I think every case when you're prescribing or seeing someone, and most prescribers would be doing this, but you're doing a risk-benefit analysis on everything you prescribe, right? And like the case I had mentioned, someone who's had multiple overdoses, well, benefits way higher on getting them started on opiate replacement therapy, versus someone who's in chronic pain, who's maybe just starting to abuse a little bit, they're not sure, well, that risk-benefit isn't quite the same in that context. So I guess that would be my message, is to whenever you write a prescription, think about your risk-benefit of prescribing, and think about alternative therapies that can complement your prescribing or even replace your prescribing.
In terms of sort of going back to trauma, because I'm envisioning sort of a very eager, prescriber who, really wants to acknowledge a patient's trauma or, experiences of stigma or whatever. And, maybe the question that they might ask would be, well, should I sort of ask about trauma right away, right, on the first visit, or or should I really acknowledge the stigma, right away, in their eagerness to help and to be of use? What would you say to that person?
I would say hold off.
Yes.
I mean, an initial visit, as far as the medical perspective, there's a lot of kind of just rote like information gathering that you should do, that you need to do. And so, yeah, I don't rush into that. I mean, I think you can get some of the family history, as you would with any medical history, and you get hints of it, but you have to develop a relationship before you really get into it. And to be honest, I'm lucky enough to have a very good team with lots of, counselors and a great nurse, and so sometimes I don't even get into it myself. But we have rounds and we discuss, and I get to know a little bit about the patient with talking to my team members. Because my time with the patients is limited, and to open that can of worms without being able to close it or to deal with it I think could be more harmful than beneficial. So acknowledging it, understanding it, and having a softer approach to history taking, and to have an open discussion. Some of these things we've talked about, give them options in their treatment plans. I mean, I think that alone is enough to mitigate some of the stigma and trauma. I think you don't have to jump into, getting into details about it. I mean, I often will ask, and then you can immediately see patients kind of like, oh, I'm like, we don't have to talk about it. Just, have you had instances in your past where you've had, some sort of trauma? And then you can feel the tension.
Right. Yes.
And then I'll just say, no, we don't need to talk about it. I'm just going to put in my note, and then whenever you feel comfortable, you can talk to one of our team members, and maybe that'll help you, along your journey. Maybe it won't. Some people just want to move on too, right? So.
I agree with Greg that sometimes it's good to hold on, and especially for, as you say, the RAAM is the same thing. The time that the physicians spend or have available for the patient, especially on the initial visit, is quite limited. And so if they're seeing that very new patient for the first time, probably not a good idea to do that. For me as a nurse and for the outreach workers that we work with, I think we are on a little bit more of an advantage in the fact that we have more time to spend with the patient. And I tend to ask, but it's not direct asking. And maybe I can share a little bit of how I try to go around having that conversation. And one of the things that I do is when I get someone into the office, obviously I explain who I am in my role there, and that I also ask the patient, do you feel safe or are you comfortable for me to ask you some personal questions? Or take some personal history, because it can be uncomfortable. And I also let them know that they don't have to tell me. They can be quiet, but that's not going to change anything. And if they don't feel safe, I am not the only one. There are other members of the team they can talk to. So I start with that openness. And the other thing, as I mentioned before, is once I understand how they came and why they came, if there is a mention of, I have noted I have a problem with my substance, whether it's alcohol, whether it's opiate, or whatever I'm using, and I want to do something about it. My question to the patient is, why do you use that substance? What does it do for you? I want you to think about the good and the bad, because there could be some really important things that it's doing for your life, and there could be some, not so good. So what are those? And in laying those out, oftentimes you hear people say, it does help me sleep, or it allows me to go to work, or to be able to do the things that I do in my life. But yes, and I don't like the fact that, I'm hiding it from my spouse, or my kids see me intoxicated, and all those. So when you hear that, I often ask, and how did that start? How did it start? A lot of the time you hear stories from it started in my years in university. or childhood, or when I got married, or when I got this job, or all those experiences. And that kind of lets itself into a conversation of what was happening at that time. Did something happen at the time? So the way I think I ask is not one that is going to, oh, I don't want to talk about that. It's really having the patient lead me into that discussion and try to explore. And once I discover that, and I say, you know, a lot of the time they will mention, this has been so hard because, you know, I don't want to use, I grew up in a family that these things weren't there. I feel, you know, I am a failure to my family, and I address stigma at that time. I say, you know, part of the reason that this feels so shameful and you feel so guilty about doing it is because of the stigma that is attached to substance use. That this is a chronic problem that any other person who may be struggling with diabetes and, you know, and have out of control sugar intake or anything may have, you know, symptoms from their blood sugar levels. But because you drink a little bit too much, you may experience the same symptoms. You may fail to do some of the things you do. However, as a society, we don't look at that the same way, and it's because of the stigma that we have as an experience that anyone can go through.
Yeah, I agree. I think as in the community support or outreach worker roles, we do have more latitude than prescriber. And I know with the nurse practitioner, she's really focusing on, you know, giving information, having that conversation, I think very, you know, informally at first, and again, assessing the risk all the time as to whether this is someone who could start on Suboxone right away or those kinds of things. So very much to your points, Greg, and I think that for the community or social work roles, we're able to, you know, have a little sort of say like, okay, so what's been happening for you? I try to start like what's happening right now. And how can we best support you? What can we do? What are the things we can do? The other elements we can add in addition to maybe if you're going to try some medication. So again, that's just like one piece of the puzzle. And I find that most people are fairly forthcoming. They'll give me a lot of history and are feeling fairly overwhelmed by their current situation and also many events that have happened. So it's kind of like trying to unpack some of that, you know, give perspective and begin the work and sort of figure out, okay, what are all the things that we can do, both practically, you know, emotionally, spiritually or culturally that will help this person in addition to the sort of medication piece, right? So bringing that to the conversation. So I don't go in with that kind of like, okay, tell me, but more to be like, tell me about yourself and tell me what's happening for you right now and how can we best help you for what's happening.
So it sounds like from all three of you and all of your different roles that what's very similar is that you take the time to create this environment of safety, right? And that's very key when we're talking about trauma-informed care. In terms of, sometimes we've had some questions about just maybe even the physical space of the places that you're practicing in, how sometimes the actual physical space can be very stigmatizing. Are there some things that you know, you've done in your physical space to minimize that stigma, or things that you're aware of that might be potential areas of stigma? So these really kind of fundamental practical things that maybe people can actually do, you know, to sort of think about how do clients feel when they step into your space. What are some things that we need to be cognizant of in order to reduce the stigma?
I think for our space, one thing that's been really, I mean, we have two spaces. One is embedded in our community health center, and there is a bit of a separate waiting room, but the waiting room is not only just for RAAM. So I was excited about that potential when we started because I think it really reduces that stigma of walking into an addictions clinic. You know, you're just walking into the community health center. So I think that's a huge advantage, and I've had some patients then say that they like that aspect of our clinic. Our other location is in the detox building, so we get a lot of people just coming down from detox, which has its own benefits because then they don't have to leave the building, and it's a safe space, and everyone in that space is struggling with some form of use disorder. So yeah, I mean, if you can integrate it into an existing clinic, I think that I've had positive feedback on that. or have it in a space that's already kind of defined as a use disorder kind of space. To offer both is nice. Yeah.
So when we're like located in the community, and we're co-located with our day treatment program, which is people were wondering how's that going to work, because it's a little more of an abstinence-based program, and loosely in the sense that they ask when people come to the program between the hours of 10 to 3 that they're not under the influence or not using. So it's not sort of a, you must be this far along in your abstinence journey. So it's fairly flexible, and we have just lots of Indigenous artwork on the walls. It's like a very welcoming space. There's, people can burn medicines, so people can use sage and sweetgrass and smudge in the space. So there's sort of people feel that welcome into the space as well. And again, we don't have our own individual waiting area, so people can sort of be with other folks that are in the day treatment. We've had a lot of people that had one referral from a community agency, and I went and met the woman there, and I brought her to our space, and then I was talking to her about the addiction medicine program, and then I sort of said, she looked at the calendar for the day treatment, she said, well, I don't think I want to try any of those medications, but I'm very interested in this other program, and I see you have a traditional teaching group and a mindfulness group, and I said, well, this is like the other program, but you're welcome to become involved in it. And so she did, and she's done amazing. So it was very seamless that we were able to sort of just, she went right into the other program. It fit her needs. Just having the programs co-located and having people being able to move freely between the programs has been really helpful. And then just the physical space itself being welcoming.
Like Sheryl and Greg have said, our program is also co-located with other departments, which is really good. When they register at the same desk, they also wait in the same waiting area. That can also be problematic to some patients at the same time, especially when they are experiencing withdrawal and there's families here with kids, and there are people patient may be loud, then that is causing. So there is that give and take. However, I think the overall inclusion is one way to minimize the stigma around it. Our registration staff who register patients, we've trained them so they know how to kind of pinpoint some of these anxiety issues, someone who may be uncomfortable, maybe in withdrawal, and they can just give a call to myself or the other members of the team to say, could you come out here? I'm concerned about a patient that I can see in the waiting room. Or, they've come, they just sat on the chair, they haven't come to register, but I think they may be here. Do you want to come and just talk to them? And they'll tell me, oh, that's a person. And, we have ways to make sure that they're comfortable. So there is that. And the other thing that I think we've made, personally I try to do is kind of keeping in mind that this is a shared department. The good thing with our department where it's located is that we don't have patient versus staff bathrooms. Our bathrooms are universal, and so some of the things that helps personally to be able to minimize the shame and the stigma with these patients is if a urine, for example, is required to kind of, required to start treatment, and someone is required to give a urine sample, I am able to ask the patient, are you comfortable? Because there are so many people around here to go into the bathroom and give me a urine. And I say, because I have an option, I can go in there myself, leave the bottle, I will put an issue in it, but I can know. And when you come out, just let me know, and I'll go in there and take the urine and bring it to a room where we test. So some of those little things, they mean so much to these patients, because having to walk around with a urine bottle and then come out with it on its own, it's like, why do you need one? Well, I'm going to see Dr. So-and-so, I don't need one. So some of those things that are really helpful, and I think we've been fortunate enough to share the bathrooms that we're able to do that. Yeah.
And I think you bring up two good points. One is in terms of staff and educating your staff, your frontline, your receptionists, or your people who your clients will see first, in terms of what are the ways to minimize stigma, even in the simple process of registering, or how to sort of demonstrate that we're a caring environment, and giving them strategies when things do become a little bit maybe challenging or difficult, and sort of knowing that there's somebody on the team who's willing to support them so that they're not all, by themselves out in the waiting room trying to manage, a bunch of patients out there. And then the other point that you do bring up is, those small little things that we can do in the sort of innocuous processes that we sometimes forget about. Something like, maintaining perhaps someone's dignity around a urine sample, or privacy around a urine sample, and those small little things that we can do, if our space allows it, to minimize